Welcome back to a podcast to answer your questions on addiction, recovery, and mental health by Waismann Method Opioid Treatment Specialists and Rapid Detox Center. I'm your co-host, Dwight Hurst, joined as always by Clare Waismann and David Livingston. Today we are talking about the history of treatment, both mental health and addictions treatment. We've got, obviously, between the three of us, we've got some experience working in there, and we've seen some things happen. And, you can go back in time. I guess that's how history works, right? You go back in time, but you can go even further back, and we can talk about some of those elements of how, where treatment's at now, and I guess how it got there, as well as what people used to do. I think that's general enough. We can almost say anything, right?
It opens the door.
I always like to get a measure of what our own sort of reactions are to the question. When I hear this, it made me think about, what do I know about history of treatment? And I went back and mined data out of an old podcast that I did on another show with a historian, a history podcaster. We talked about some of the history of mental health, and I did a re-listen because this was years ago, and found some interesting bits there. Because my first thought is like, what did people do, and why? That's my first. What are your impressions when you hear that idea of what is the history of treatment?
Let me start by saying I'm definitely not an expert on the history of addiction and treatment. So I'm sure there's a whole lot I don't know. And Dwight, I'm sure you can fill in a lot, given your earlier discussions. But as far as I'm aware, I think that really that AA brought about an awareness and an initial approach to the treatment of addiction. A lot of it through Alcoholics Anonymous, and then it's expanded. And from what I'm aware of, that was really one of the primary and most substantive approaches, and where people went to for a long time. And beyond that, I think they probably went to their doctors, and I don't think there was a lot of treatment. And I don't know a lot about this, so I can be wrong, but I'm not aware of even the mental health community really paying attention to it at the level that is certainly not like it is now, where it's a major part of treatment. But so that said, there's a lot of overlap. Okay, and there's a lot of overlap with compulsivity and a lot of other things that have been treated for a long time. And maybe that's something we can sort of talk about a little bit as well, since it overlaps, but I'll leave it at that.
It is one of the biggest parts of addiction treatment history that I always think about is how the criminal justice system got involved, because we as a human race, I guess, or a treatment community, medical community, really didn't have a lot of tools or understanding of how to measure things with, especially things that if the main organ that's being targeted or focused on is the brain, we've had leaps and bounds in the last few decades of how to analyze different parts of the brain and see things. But because addiction ties in with behavioral problems, I think that's where it was relegated a lot to the police, right? As you say, going into the doctor or, and you go back far enough when we didn't really have treatment. It was only in especially in the U.S. and some other areas, there wasn't really any treatment before the 1800s. And it was in the later 1800s they started developing anything. And I think there's a lot that was, let's say, lacking there at first in what we'd see today and consider to be treatment. But
yeah, unfortunately, it's still lacking.
Yeah.
We are in 2023, and it's amazing, not just the lack of treatment, accessible treatment, but the lack of understanding of what substance use is. So I think you touched where any history of this condition, if it's mental illness or addiction that is, so often related, is truly the evolution came from knowledge, from understanding a bit more of neuroscience and how our brains function, and how substance can affect not just its function, but the nervous system as well.
Yeah.
When you speak about addiction in relation to crime and how it became almost people view as the same issue, one and the other. I think it's because, again, people did not understand why people behave that way, why they couldn't stop themselves from abusing whatever substance. So they kind of put themselves in the same room, held each other's hand, so they could try to at least stay away. And again, one day at a time. It was truly, and it still in a lot of places is a torturous way of dealing with this issue. I think not just with depression, not just with substance use, with so many other mental health issues, medicine has come such a long way, where we can treat people, where we can block physical cravings, where we can reverse a lot of the mental conditions that leads people to use substance. So I think it all starts from diagnosing.
Yes,
self-medicate.
Even just tying it in with illness. And I think people who are, especially young people nowadays, as there has been more and more emphasis on addiction and the disease model and understanding the connection of self-medication and mental illness, people may take it for granted that that's what it is, but it was, but it was not always understood that way. And, funny enough, when you go back to some of the early mental health, they had some knowledge that the brain in the head did something. And I don't want to make, I don't like when people try to make people who lived a long time ago sound dumb. I mean, they just didn't know, right? But they realized it did something, and there were some theories that basically that mental illness was caused by, and I don't mean to be silly, but a bonk on the head, sort of. If you got your head, injury, and at the same time, so that was progressive in a way for back then, but also what we consider to be very regressive. That was still treated as a moral, hard work, and whether it was church going or whether it was whatever it was, becoming a better person, great aspiration and part of health, but that was considered, it was treated as a moralistic failing, even though there was some thought that there might be a physical component.
If you think about it, then in some cases they even use exorcism, right?
Absolutely,
to deal with mental illness.
Exactly. It was thought of to be satanic possession for, and I won't say that that's completely gone, but I would say mostly in the mainstream. I don't hear people usually saying that. I'm not going to say that it doesn't cling on somewhere, but, and you go back even further, even other considered physical. I mean, I don't know, you go look in the Bible. It talks about, hey, this guy's blind. What did he do wrong? Not to go to the way back, but a lot of things were treated that way, that you were possessed by a demon or by the devil or something like that. And exorcism practices sometimes were very physical and killed people.
Right.
Which is kind of the same as trying to go through your own, either self-medication can kill people with addiction, or even trying to go it alone. Right before we hit record, we were talking about Claire and I were just talking about the basement bucket blanket, is what I call it, mode of detoxification, where someone just sits there and tries not to use and gets really sick and hopefully lives. But that's not a guarantee.
Yeah, no, I was actually speaking about that. I truly believe that people, they're just starving for an answer, for a solution, not just on addiction issues, but also mental health issues. And unfortunately, unfortunately, there isn't. There is not a single answer for everybody. There is a combination of factors that disrupts the nervous system response. And it could be from childhood experiences, biological factors, environmental factors, DNA. So it's really going back to that proper assessment, the individual assessment, and then going from there. It could be a combination of treatments from therapy to medical detox to medication or some kind of chemical imbalance. So unfortunately, there is not a answer, but there is a combination of very effective treatments that can actually reverse a lot of the conditions that we see people self-medicating for.
Yeah, that's right. Right. So, like you said earlier, Claire, it begins with a comprehensive diagnosis because you have to figure out is what's driving the compulsivity. Is it psychogenic? Is it biological? Does it have to do with your environment per se? Is it and then you can start to break all of those things down immensely. So we are at the root a compensatory system. You know, a human beings compensate one way or another, and so a lot of what addiction is a compensatory system. So if you can't sleep, and then all of a sudden you're introduced to an opioid, and all of a sudden you can sleep, well, you found something to compensate for an anxiety that comes with lack of sleep, the fatigue that comes, the dysregulated nervous system, and all and on and on. And often people don't seek out a sleep study or a remedy that is non-addictive or things like that. And they've kind of found something and they'll end up addicted to it or something. So it can be as simple as that. It's often more complicated. Sometimes people just are introduced to it recreationally and they end up liking it. And that can be another component of it. So you have to diagnose it. And I think that historically there's been a lot of shame and it's been and like you were saying, Dwight, about the legal system getting involved. I mean, it was very punitively addressed. I mean, there's the amount of people who went to jail for marijuana, and now I know it's not federally legal, but it's legal in a ton of states. And you think about the damage. And so I think there is an evolution in us understanding we're just dealing with some chemicals and people compensating for something that needs to get dealt with and diagnosed, and then and then you can put together a comprehensive treatment. I think most of what inhibits that from actually succeeding is people don't stay in treatment or feel enough confidence that there is a comprehensive approach that's ongoing until things truly get worked out. And we're, I think, better at diagnosing than we are, than we are actually at treating often. And so at any rate, and I think that's been the case for a while.
You know, I fully agree. One of the things I went over to my bookshelf, and thank goodness it was still there. It shows everybody how often I clean out my bookshelf, I guess. But from that podcast I did way back when, I have a reprint of one of the first diagnostic manuals, and you just triggered my memory here as you're saying that. It's from 1918. It's called the Statistical Manual for the Use of Institutions for the Insane. And when you get to this idea of we're better at diagnosing than treating, it's interesting to see the little seeds of what eventually becomes our understanding. So in this, they have what I found about addiction is they have a diagnosis here, what they call alcoholic psychosis. Which is an interesting terminology, which I would say neither of those probably meant the same thing to them that they mean now. Neither of those words, alcoholic or psychosis, at least they were understood differently. But it says some of the interesting things in here. It says that diagnosing alcoholic psychosis, as they called it, should be restricted to mental disorders arising, with few exceptions, in connection with chronic drinking. So you can see where they maybe had it backwards of what you're saying. First of all, is that the chronic drinking, the overindulgence in alcohol, as it's put here, is often found to be, here we go, here's what ties in, merely a symptom of another psychosis. So back then they knew that there was some regard for self-medication, and at the same time they couldn't help but call it, later on they call it a slowly developing moral, volitional, and emotional change in the chronic drinker as one of the symptoms, which once again we can see when we talk about some of the things now modern. There's little seeds of that there, but it still brings in this kind of like there's a moralistic perspective that's still there that ties in a lot with shame. And opiates, by the way, were not even addressed. It says opium and derivatives as a footnote, that it's possible people might use that or abuse cocaine, bromides, chloral, or etc. Anyway, so it's interesting to see where they started to get some seeds of something going on with the brain physically, and there's some form of self-medication, and then the treatment just eventually, we see where, as we've said, it diverged into just, well, I don't know. I mean, kind of, it diverged into that, and then, of course, you get the behavioral problems, you get the shaming, you get the exorcisms, and then eventually police interventions, and things like that, particularly for those that couldn't afford to just keep their loved one at home and monitor them, which, if you happen to have a family that had the wealth and resources and cared to keep you home, otherwise you were kind of in trouble. So that's a whole big bite there that I just took of the history, but I thought that was very interesting.
No, it's interesting. It's that thing, who came first, the chicken or the egg? I think there are both circumstances where people will be self-medicating of substance because there is a misdiagnosed or undiagnosed issue. And there is the times that their nervous system did change due to substance use. So Absolutely. It can happen either way.
I once worked at a place where we were discouraged from diagnosing bipolar disorder, and I don't totally agree with this, but we were discouraged from diagnosing bipolar disorder until someone had a certain amount of time off of methamphetamines because it mimicked it so well. Now, I don't think that's always the best way to go about it. I think diagnosis can be made, at least symptomatic diagnosis pending, can be made while someone's still using, and it sometimes is very important. But it was interesting, the acknowledgement. And this is a few years ago, right? Of like, oh, well, some of the substances might be being wrongly classified. And then, so even just in the life of a career now, I think we've seen a lot of differences take place, right?
Yeah, there's even brain scans, often patients will call and say, oh, I just did a brain scan. And it's all over the place. And of course it is. A, you're using a tremendous amount of drugs. Mm-hmm. There's chaos in your nervous system. And B, often there are issues that made you start the drugs in the first place. Yeah. So, yes, the good news is that people are seeing it more as a physiological issue and not a personality issue.
Yeah, one of the interesting, and this will be interesting when we look at modern residential or inpatient stays, which are generally fairly short, and you guys noticed that with Domus, but back this was somewhere in the mid 1800s, and so they started to have actual recovery communities where they would actually build little towns. One of the first ones was actually a town called Pilgrim Asylum in New York, and it was self-sustaining. The people operated, there's, businesses, bakeries. They had their own fire department. In fact, they were responsible apparently for sewing and putting together their own straitjackets, which were used then when people were in a psychotic episode. And so they had to do everything themselves. But one of the sides there is that people would live there for years, if not the rest of their lives. And so at the same time that they were encouraged to have a life, and they would read, they would fish, they would go on nature walks, they were encouraged to be healthy. At the same time, they were pushed over in this area and said, yeah, you go over there now. We don't want to have you around normal people. And so you look at that compared with nowadays, where I think we look at those treatments, at least the preferred method of treatment is to say those are short-term things to get back to your life, integrated with your life.
Don't you think that's how it should be?
Oh, I mean, it makes sense. I mean, yeah, I'm much more a fan of not pushing people off to the side. But I think socially that still
Right.
happens, right? But hopefully the treatment is designed to get you back into your life. And well, I guess that's one of the reasons why we now do treatment. That's another change, is that we've relatively recently, you could say, decades and decades ago, started to treat the family system, that there's often problems inherent to relationships that can be triggers for relapse, right? And other things like that, to where when someone comes in, if their loved ones are like, fix this person's problem, a lot of modern treatments are going to say, you come in too. Hey, step in to the office with us sometimes. And let's look at the whole system, not just labeling the person as a problem, right?
If the family can be the reason for a relapse, so is work, so is the girlfriend, so is a friend, and I think we have to concentrate on treating the patient and giving them, the strength they need to walk the healthy path they're looking for, regardless of circumstance, and how to deal with frustration or sadness or any unwanted feelings without relapsing.
Right. So, part of it, as you're bringing up, Dwight, is age dependent. If you're talking about someone who's younger or a child or something, then their family system is really a bigger part of it, and because they're dependent on that system largely until they're older. But because we work primarily with adults almost entirely, what it becomes there's triggers in the world always, which isn't to say that you shouldn't get away from them or minimize them or make sound judgment in terms of the pressures or the things that are upsetting to you. But so that's from the outside. From the inside, you also have to develop a capacity to tolerate ambivalence and be able to understand that within this world, there's things that we love and hate, and that will never change. So part of it is sort of moving, at a certain pace. So let's say someone's got a severe anxiety disorder, okay? Then you add a trigger or whatever that might be for them onto that. That can push them to the point where their ability to compensate in terms of their ego structure and what they can manage starts to feel compromised. So it's really, like we were talking about before, it's really kind of specific to the resources the individual has externally and internally, how much they can tolerate, and that varies a lot. And then really, I think people don't stay in treatment long enough. I really don't think so at all. In fact, the evidence is that when you stay in treatment much longer, the effects and the prolonged effects are much better, because there's a lot to get worked through. It's like learning anything. And so, I'll leave it at that.
It's an old-fashioned concept to say that once you get off the stuff, off the sauce, or off the drugs, then you're good, right? And there is that idea, and it mostly I see that nowadays existing in the minds of non-professionals, thankfully, who don't know as much about it, right? But I think it helps the focus. What you're describing puts the focus more on, okay, let's assume I've been clean or not relapsing for a period of time. Rather than leave treatment, often it would be recommended to stay. And at that point, I have to start talking about something else. So we start to, if we haven't already, we have to start talking about, now what with my health, right? And we're going to address those underlying mental health issues. And and a lot of times, many of us find that attending to our psychological health, that's just another system. I should attend to my cardiovascular health, right? I should attend to all aspects of my medical needs. And then I think it puts that emphasis on, I'm getting some treatment for things. I'm maybe medicating appropriately, whether you mean metaphorically with behavior or literally getting medication prescribed to me. I'm not self-medicating anymore. I'm getting professional advice and feedback on that. And so you're right. I think you're absolutely right. It takes the emphasis off of just the substance as being the one thing that has done everything to me, right?
It's been so overdone that the substance is The substance is the thing that, I say this all the time in our discussions, but it is the compensatory mechanism. It's not the issue per se. And that's a great relief. So once you're off, unless you feel exceedingly vulnerable to relapse early on and so forth, in which case you do have to pay attention to that and take a bunch of steps. And that can get complicated because there are some people whose the way they're built internally are at risk of impulsive and compulsive behaviors at a far greater level than others are. And that's often no fault of their own. It's just how they're organized internally. And so when that's the case, you take different measures. But regardless, you want to, the goal is to help to build a life you really like. So you want to protect it. And so you don't need to compensate. And if is the things that, as you start to feel confident that the things that are causing the compensation or the need for compensation are getting better, you're on your way. And that should be the focus, whether it's biological, psychological, in your environment in some way, to be differentiated.
I think, Dwight, what I don't know, David. I think what you're saying, that I'm listening, is instead of sustaining recovery, that is, the normal approach in the addiction field, is working on a productive and happy life. You're not sustaining anything, you're adding to it. You are, the other term we can use, you're just adding to the quality of your life and making something that you really like to be part of. Instead of just, I see it instead of a baseline or a straight line, I see it as an improvement, as every day being better for yourself, right?
Absolutely. That your needs are going to persist forever. So when they say addiction model or the disease model, what I hear, and I hate the word disease in this because I think I think in one way it makes people feel like, okay, I'm not responsible for this, but in another way it confuses the fact that our needs are not a disease. And yet they will go on forever. And so what we have to do is realize that fact and then get them met in a varied in varied ways that feel right enough to us. So if they're getting met in a whole bunch of ways, then all of a sudden our life feels good to us. The desire to compensate goes way, way down. So that's a treatment. When I think of a disease and I've said this before, like if I get a cold, the cold is happening to me. Okay, our needs are happening to us. My need to eat will never end. Okay, and my need to drink will never end. My need to have good companionship will never end. Okay, and my need to exercise, play, sleep, all these things, these needs never end. I don't like the word disease because they're not a disease. They're the lifeblood of all of us. But as these things are getting met well enough and we're feeling good in our life, then what's the need to compensate? So, at any rate, repeat myself.
Point. No, it's a really good point when, I think it also goes to show the evolution we're talking about, right? Because going back to, it's funny, this old manual of diagnoses, about, 75% of it is instructions on how to collect data. So there was a certain acceptance of not knowing what was going on that was true then. And I think we look at that and we see an ongoing evolution where, it was groundbreaking to say embrace a disease model, as we put it. And you're bringing it, I think, to that next step in evolution, which is to say, well, why don't we just talk about our needs, right? Which, that's it. I can totally understand as you're saying that it is less shaming, and also not just from an emotional perspective, but practically speaking, I think I plan out my treatment planning or my health sustaining behavior differently if I look at it as I have needs and that's okay than if I have a disease. So that's very interesting as you say that. I hadn't looked at it that way.
Yeah.
the world of psychology and so forth has always sort of been trying to navigate and for good reason, because all this stuff is connected between the, biological and, your family of origin and, your environment and all of these different factors within sort of then your own needs, which is really more of your psychology per se. So, there's all these factors going on, but they're not that hard to break down and see clearly. It's really possible.
Shifting your perspective, seeing yourself through new lens.
If you're in treatment and you don't know why you're using drugs, that's not a good thing. You should absolutely, if you're in treatment, you should absolutely start to get a clearer and a clearer and clearer and deeper idea of why you are. It should be clarified. And if you're just thinking, well, I have a disease, you're not getting to what you need to, because your needs are not a disease and they will continue forever.
And that's what happened to most people sitting in treatment. They receive the explanation that is a global explanation. Why I use drugs is the same reason why another 30 people here use drugs. And that's so far from the truth. And it makes you feel so isolated and misunderstood that might as well just walk away.
Right. And then where am I moving to? Because we're always going to want something. And we also want different, the brain likes different experiences. And so we're going to want something and we're going to need things. So, let's define what those are. Therefore, build a life that's right to what we want. Not easy, but that's why it takes a while.
And we're going to leave it there for today. Thank you so much for tuning in. We are always endeavoring to bring you the cutting edge and best information that we possibly can on the world of treatment, mental health recovery, and opioid detoxification. You can add to our program by sending us your questions. Send them to info@opiates.com. Go to opiates.com to learn more about Waismann Method, or follow us on any of the socials at Opiates. This show is a product of Waismann Method Opioid Treatment Specialists and is produced by Pop Collar Productions. Our music is the song Medical by Clean Mind Sounds. And this week, as always, I'm Dwight Hurst for Clare Waismann and David Livingston. I want to thank you once more for tuning in and remind you to keep asking questions, because if you ask questions, you will find answers. And whenever you find answers, you can find hope. Have a great day. We'll be back soon.